Righty. I think Berna and Grace are here. Sergey, David are here. Okay. So this is the last EP conference for Grace and Perna as senior fellows. Congratulations.
Thank you, Dr. Pass. It won't be the absolute last for me. I'll still be joining.
I think this is, thank you. Yeah, I've been here for your entire fellowship. So for 3 years in a row, you have come to this conference every Monday. So good job, good stamina. All right. So, so next week we'll do our basic EP review for the new incoming fellows. Anybody interested can join. I figured we'll do a couple more board review questions today. It seemed to be popular.
Dr. Pass, we see a presenter view.
Thank you for sharing that with me. Let me have a better idea about this. Thank you. Is that better?
Yeah.
Thank you very much. See, after 3 years, you can correct me. Okay. Here's the first question. The intracardiac electrogram in this figure shows an HV interval of 9 milliseconds. What does this indicate? I'm going to ask Dr. Bonsall what she thinks about this. The choices are first degree AV block, second degree AV block, infrahisian conduction delay, pre-excitation, or finally bundle branch block. And of course, you recognize that this tracing is run at a very fast paper speed, so probably 200 millimeters per second.
Pre-excitation.
Pre-excitation, and explain your thinking on this.
The normal HV interval should be around 50 milliseconds. And then if it is less, then it's pre-excitation. It means it's going through the accessory pathway.
That's right. Very good. So that the ventricle is being depolarized earlier than it normally would because of the presence of an accessory pathway, allowing for excitation, or for lack of a better term, pre-excitation before it normally would. So as you correctly pointed out, the normal HV interval would normally be between 35 and 50 milliseconds. And having such a short HV interval is most consistent with the presence of an accessory pathway, allowing for so-called pre-excitation. So this is not first degree AV block because the PR interval is not abnormal. Second degree AV block of any sort, we would see some P waves that are not conducting, and we only have one beat so we can't really say, but there certainly is no obvious evidence for that. Infrahisian conduction delay would be consistent. What would the HV interval be, Perna, if the patient had infrahisian conduction delay?
Be more than 50.
Right, it would be long. It would be like 50 to 100 or 200 milliseconds, or perhaps even infinitely long, no conduction at all. That is, in fact, what we believe patients have when they're in complete heart block. And then in a bundle branch block, it's hard to tell if this patient has bundle branch block just because the paper speed is so fast. But again, if someone had bundle branch block, usually the HV interval would be prolonged, or could be prolonged. Okay. Here's our next question. A 6-year-old presents with the ECG shown in figure 6.27, the one right there. He is defibrillated back into sinus rhythm. Which drug should be avoided in this patient who presented with this ECG? And the choices are propranolol, aspirin, Coumadin, lidocaine, and erythromycin. I'm going to turn to Dr. Tulsi Condon of the Upper East Side of Manhattan to see if she can provide What is this arrhythmia, and which of these agents would not be a good idea for a patient who had this presenting tracing?
It looks like torsades. So we would want to avoid anything that prolongs QTC, which would be erythromycin.
Absolutely. Outstanding. Excellent answer. Correct. So this is an example of torsade de point, or the twisting of the point. So this is so torsade is formally defined as polymorphic ventricular tachycardia in the setting of a long QT interval. And now we can't tell that the patient has a long QT interval from this tracing, obviously, because we're in torsade here, but it's a very rapid VT. So propranolol actually would be a therapy for people who have a tendency towards torsade for long QT. Aspirin would have no impact one way or the other. Similarly, Coumadin or warfarin, no impact one way or the other. Lidocaine could theoretically be useful for some forms of VT, and is generally not contraindicated in people with long QT. And in fact, for sodium channelopathies like long QT type 3 may be a useful agent, but certainly would not be an agent that we would necessarily avoid in someone with torsade, although it may not be the first choice for treatment. And clearly erythromycin would be, which is a macrolide antibiotic, is a important concern. We want to avoid any agents that can prolong the QT interval. All macrolides can. So in common pediatric practice these days, the most common one that's used is azithromycin. Have to avoid that. And again, I would remind you that when you have a patient with long QT, you want to sign the patient up for the website crediblemeds.org, because they keep track of every agent and what is known about the potential for interaction with people with long QT syndrome. And what's nice about the website is if you sign up, they send you updates. And, one of the things I find annoying about the site is that you have to sign up. But the reason that they want you to sign up is because they want people to understand that the knowledge of agents and their interaction in the setting of long QT syndrome can change. And so they don't want people, for example, to download a list and then never look again, because the information that we have on these agents is changing all the time. And so there are agents that may not have been recognized today to be dangerous, but may be reported in the future. And they keep an eye on all of that and update it regularly. So this is why they won't allow someone to just access the site without at least signing up. It's free to sign up, though. Okay, let's move on. The next most appropriate step for the newborn patient with this ECG is which of the following? The choices are A, cardioversion, B, adenosine, C, ventricular pacing, D, lidocaine, and E, verapamil. And we're going to turn to our neonatal expert, Dr. Zawani. Tarek, do you have any thoughts on which of these choices would be your next most appropriate step in this newborn?
So I think this looks like a flutter. So I think the next step is not said there, but it's going to be sedation and then cardioversion.
Okay, well stated. Yes. So cardioversion is correct. That would be the next correct choice. Why would adenosine not be the right choice, Tarek?
Because with the adenosine, we'll just block the AV node, but then we're not going to stop the pathway.
Right. It wouldn't stop the flutter, right? It would just more demonstrate it. And in fact, this tracing has an episode here of transient block, right? Mm-hmm. So you're basically getting what you would see with adenosine without needing to give adenosine. Yeah. This is one of my little pet peeves about kids who have babies with atrial flutter. It seems that even if you have a tracing like this, neonatologists always like to give a dose of adenosine to really slam home the diagnosis here. But I think one could easily say that we don't we don't need that to make this diagnosis. What about ventricular pacing? Well, that would have no role for in this at all. I think that's probably intended to trick you when you see this little area of potential block, but this is probably a situation where there is concealed conduction into the AV node causing block because of the very, very rapid atrial rate, which in this case is above 300 beats per minute. And Tarek, is that typical for newborns to have an atrial flutter rate above 300?
Yes, I think like they can have like between 250, like usually it's like 2 to 3 to 1.
Yeah, so actually babies often have heart rates this fast, could be even faster. So, you know, it's always important when you're looking at newborn tracings, right? If you're over 300, 1-to-1, the choices are either going to be, or let's just say if the ventricular rate is over 300, the choices are either SVT of some sort, meaning ORT or AVNRT, or atrial flutter. And in flutter, typically in newborns, the atrial rate is very, very rapid. Lidocaine would really have no role in this, in the management of this, and verapamil we've discussed is generally relatively or maybe even totally contraindicated in newborns because of the concern for cardiovascular collapse. So really the only option of that makes sense is cardioversion. I can guarantee you that everybody on this call will at one point be asked by somebody who is treating this, can we put the child on a beta blocker or on digoxin or something like that? And the answer is you can, but the likelihood that it's going to convert is not very high. And there's really no obvious benefit to leaving a child in this rhythm for any longer than they need to be. So, I would not generally favor that. Okay, next question. An asymptomatic 14-year-old patient with a normal examination and resting ECG has a 24-hour cardio scan, which I assume is another term for a Holter or something like that, showing the finding here at rest and sleeping. The rest of the Holter is normal. Which of the following is the next most appropriate step? 1, EP study. 2, exercise treadmill test. 3, reassurance. 4, initiation of a beta blocker. And E, pacemaker implantation. So I am going to ask Dr. El-Faturi if he has any thoughts on this tracing.
Good morning.
Good morning.
So looks like second-degree heart block.
What type?
I would say it's Mobitz 1.
That's correct. We're looking at Mobitz 1. Okay. So what would your answer be then, Mahmoud?
I would reassure the patient.
Okay, that's correct. So we've talked about how Wenckebach when sleeping is a normal observation. And we see here the very typical lengthening of the PR from this beat to this beat to this beat until finally there's a drop. And, you know, sometimes people will say that, you know, a good way to make the diagnosis of Wenckebach is to look for so-called grouped beating, where you see a couple of beats that are conducted at a certain rate, then a pause because of the block, a couple of beats conducted and a pause, and so on and so forth. So yeah, Wenckebach in a person who is sleeping is considered a normal finding, particularly in young people who have high vagal tone. So EP study would not be indicated. And Mahmoud, if we did do an EP study and we had a His catheter in position at the moment that this was occurring, would the block be, would the AH interval be lengthening and blocking, or would the HV interval be lengthening and blocking?
I don't know, actually, because I don't understand that.
Okay, that's fair. I will accept that answer. So we're going to punt this up to Dr. Perna Bonsall, since this is the last time we'll ever be able to ask her a question in conference. So Perna, would somebody who is Wenckebaching, would the block be at the AH, which would denote AV nodal block usually, or would it be at the HV? And again, this is not guaranteed, but most of the time, where would we see this block?
AH.
That's right, in the AH. So usually, Mobitz 1 block is in the AV node, whereas or Wenckebach is in the AV node, and higher grade blocks like Mobitz 2 is in the His-Purkinje system. Not always, but mostly. Good job. That could be your final statement, Perna, in EP conference forever. All right. Okay. This is an asymptomatic 10-year-old EKG, patient EKG, during an exercise treadmill test, and his resting ECG shows pre-excitation. What does this tracing indicate? Choice A, the patient is at low risk for sudden death. Choice B, the patient is at high risk for sudden death. Choice C, the patient is at low risk for supraventricular tachycardia. Choice D, the patient is at high risk for supraventricular tachycardia. And then finally, choice E, the patient has VT rather than pre-excitation. And for this question, we're going to punt it up to Dr. Grace Kong. So Grace, what do you think this tracing demonstrates?
It looks like the pre-excitation went away, which would mean that at like a heart rate of less than 200, around 200, and I would say low risk for sudden death.
That's right. That's exactly right. So that could be Dr. Kong's final statements as a regular cardiology fellow. Correct. So, you know, we all know that the formal recommendation of the American College of Cardiology and the American Heart Association, as well as the Heart Rhythm Society, is that for people with WPW who are asymptomatic, we recommend a stress test. And if there is a sudden and acute loss of pre-excitation, generally with heart rates below 250, which of course in sinus rhythm, everybody would be, right? We can't get our sinus rate that high. That would generally connote a patient who has a low risk pathway, meaning it cannot conduct rapidly. Now, unfortunately, there are cases in the literature of patients who have had a tracing like this, which is suggests low risk, who have in fact gone on to have sudden cardiac death or cardiac arrest. And that is being used increasingly as a rationale to just EP study and maybe even ablate everyone. But we are not quite at that stage yet, I think, as a group of doctors in pediatric cardiology, but it may turn to that one day. But the bottom line is, by formal standards, this would be considered consistent with low risk for sudden death. So it's not, and again, high risk is considered being able to conduct at rates above 250 beats per minute, based on the famous George Klein paper from 1979 in the New England Journal, which I've shared with you in the past. So he's not at risk for high risk for sudden death. The patient, there's nothing about this tracing that tells us anything about SVT, because remember that having SVT and having a high risk pathway are not really related in any obvious way. So we can't really make any conversations or thoughts about SVT based on this. I think if a patient went into SVT during a stress test, you might make a comment that this patient seems to be, can have SVT, but maybe at high risk for SVT, but this is not SVT. And then finally, this is not VT. This is essentially just pre-excitation that converts to sinus, to no pre-excitation as the pathway effective refractory period is exceeded by the sinus rate. All right, let's move. Oh, one other thing I should say is this tracing is very, very rare. We don't see this very often. If you ask Rika Arnon, who does all our stress tests, she'll tell you that, maybe once in 3 years, she sees a patient who has a sudden and acute loss of pre-excitation like this. And that's part of the problem with this test, is that oftentimes you don't see this. So it's more often than not, I would say this form of testing is indeterminate. In this particular case that we're looking at, this is a very good test. It's very definitively shows loss of pre-excitation, but in practice, it is unfortunately a very common that it is not helpful. Okay. The patient with the tracing here has which of the following? A normally functioning DDD pacemaker, atrial lead dysfunction, ventricular lead dysfunction, atrial and ventricular lead dysfunction, and finally bi-V pacing. And so for this question, I'm going to turn to Dr. Sergey Bebia of New York City.
Good morning.
Good morning.
So on the first tracing, we see we see the P wave. After that, we see a pacemaker spike and a QRS complex. And then we see the same in the following. And then after the third QRS, we see the P wave, but then there's a pause and there is no spike for the ventricular pacing, which means that and then we see again that there's another there are two spikes, and then kind of the ventricular pacing. So it's probably not the ventricular pacing, because I'm looking at all the rest of the tracings. It looks like the ventricular pacing is fine. And then our options are, so it's not a normally functioning DDD pacemaker.
No, I would agree with that.
Atrial lead dysfunction, probably. Ventricular lead dysfunction, unlikely. Atrial and ventricular. I'll go with B, atrial lead dysfunction.
That is correct. And what is the problem with the atrial lead? Is it not capturing? Is it not sensing? Or is it both?
So sorry. So that after that P wave, after we see the pause, this first spike, which is different from the kind of regular ventricular spike, right? This is a could this be the atrial pacing spike?
Yeah, that is an atrial pacing spike. Yeah.
So then, so it's pacing, but we don't see so it's probably not capturing.
Well, why are you saying it's not capturing? What do you think this looks like? Does this look like it's capturing? These are the same lead, the same simultaneous, I should say. So I think it actually is capturing here.
Oh, but that's a P.
I think that's a P wave. I think that's a paced P wave, right? Like, so the sinus P wave in this lead number 2, whatever that is,
positive,
upright in sinus, but then when you're apacing, it seems to be downward. I'm not sure it's capturing here. It's hard to say, but here it looks like it's capturing, and then here it's sensing. So this looks like a case of intermittent undersensing of the P wave by the pacemaker. So I think we would say that if one of the choices, instead of atrial lead dysfunction, it asked, is this undersensing in the A? I think that's how we would describe this. So this is a problem with atrial sensing. So, all right, good job. So far, we have 100% on this test. Okay. The underlying diagnosis for this patient that we're looking at in this ECG tracing is likely to be which of the following? Wolff-Parkinson-White syndrome, renal failure, atrial septal defect, thyroid storm, or anorexia nervosa. And for this question, I think we're going to turn to our visiting resident physician, Barbara. Barbara, would you like to throw in your hat into which of these diagnoses can cause this? I think that we don't have any, there's no big boxes on this tracing, so it's hard to know what the heart rate is. So I'll make up a heart rate here. The heart rate is 41 beats per minute. So Barbara, do you have any thoughts on which of these diagnoses this might be?
I mean, I can certainly try. There's obvious bradycardia, and I would.
So which
tend
of
to
these
go
are,
with,
yes, go for it.
with anorexia, simply because associated with a lot of electrolyte abnormalities, which could cause the bradycardia. Wolff Parkinson, why it doesn't quite look like the QT interval is prolonged in this EKG.
Well, wait. Let's stop for a moment. So Wolff Parkinson White, we don't usually have a prolonged QT, right? We see a short PR interval with a delta
I'm
wave.
sorry. Yeah.
So
yes,
we don't see any
true.
I agree with you though. There's no evidence for that. Now in renal failure, do you see electrolyte abnormalities?
You do.
So,
you do see it. But then it tends to be more.
What are we mostly worried about?
Hyperkalemia.
Yeah, hyperkalemia is usually the thing we're most worried about.
Yeah, and that would cause the tall tented T waves.
Right.
Which I'm not quite seeing in this EKG.
Right. So this doesn't seem to be renal failure. What about atrial septal defect? It does appear as if there's a small P wave before every QRS. So does ASD cause sinus bradycardia?
Not to my knowledge, no.
Not usually, although superior sinus venosus ASD could cause sinus node dysfunction after surgery, but usually we don't see that, at least in pediatric patients. What about thyroid storm? What would we expect would see in the on an EKG of someone who's having a thyroid storm?
So a thyroid storm, I would expect tachycardia.
That's
not
right.
Bradycardia.
That's right. So that's right. So you're correct. The answer is E, anorexia nervosa. But the thing to remember is anorexia patients, not on the basis of electrode abnormalities. I'm not sure what the mechanism is, but anorexia patients are very bradycardic as a rule. And in fact, it's a good sort of indirect factor. I don't know what I'm sure there's a whole literature on anorexia nervosa and making its diagnosis, but certainly if there were like major and minor criteria in the raw pass anorexia criteria, I think bradycardia would be a supporting piece of evidence, because I'm actually not sure I've ever seen an anorexia patient who was not also bradycardic. And so this would be most consistent with the diagnosis of anorexia nervosa.
Okay.
Okay, good job, Barbara. All right, intracardiac tracing shows which of the following? Atrial flutter with 2-to-1 conduction, SVT using an accessory pathway, atypical AV node reentrant tachycardia, typical AV node reentrant tachycardia, and finally, normal sinus rhythm. And I will note for you here, so this is a high RA, these two channels, these are His channels, these three distal and proximal, and I assume this is an M from mid in this micrographia. And then this is the RV. And so I'm going to turn this over to Dr. David Barris, incoming chief fellow, co-chief fellow. David, any thoughts on what this rhythm is?
Yeah, I'm thinking that this is probably typical AV node reentrant tachycardia.
That's correct. And can you explain to us why you believe that to be the case?
So we have the H, they kindly annotated this for us where they put the H, the A, and then the V. So we know that this is not going to be atrial flutter because we'll see a lot of these. We'll see 2-to-1 on the A's. And then SVT with an accessory pathway, we would see the A after the V, typically more than 70 milliseconds.
Yep.
And then for typical AV node reentrant tachycardia, we go down the slow, up the fast. So I guess we'll see we'll see the A before the V. Is that correct?
Well, it'll be less than 70 milliseconds after the V. It can precede the V, right? Because the reentry is occurring in the AV node. And so if it takes longer to go through the His-Purkinje system and depolarize the V than it does to go from the AV node back up to the A, then the AV time can be negative, as is the case in this example, right? So the A is actually preceding the V. So, and then what happens in atypical AV node? Yeah, true.
So atypical would be down down the fast and up the slow. It's a wider, that one's a wide complex.
No,
is it actually, it's not a wide complex. I know that the relationship between the A and V is different. It's escaping me for the moment exactly what it would be.
so atypical has a long RP also, because as you appropriately and correctly stated, the retrograde limb is through the slow pathway. So the time it takes to go up is longer, and the tachycardia is slower, and so the VA interval is longer. So it can look a little bit like ORT, but usually the earliest atrial depolarization will still be in the His, but the R to P interval or the VA interval will be long. And then of course this is not sinus rhythm, right? Because the A is after the H. I guess it's possible that this could be sinus tachycardia with with first degree heart block, right? So, right, you could be basically conducting from this P wave to this QRS, but the problem with, but again, it's a little strange that the A would precede the A in the high RA. So this can't be sinus rhythm. It's conceivable that this could be some kind of EAT that's arising near the His and is conducting with a long AH interval to the following V. But that would be a very unusual diagnosis. More likely, this is just, as you appropriately and correctly stated, typical AV node reentrant tachycardia. And I will bring this up here. Mahmoud made the point that the bradycardia in patients with anorexia nervosa is due to an overactive parasympathetic system. So thank you for that, Mahmoud. Fountain of knowledge here this morning. And I think with that, we'll stop for today. Thank you very much. Congratulations to Grace and to Perna on gonna have a nice party on Wednesday to celebrate them. And thank you for joining the entire year. You have made it to the end, and we will resume next week. The first couple of weeks, I tend to give very easy questions, and we review very basic topics. So for our third year and second year fellows, if you're not interested in seeing very basic stuff, you can, I excuse you, of course, from EP conference, but sometimes it's helpful just to see the same things over and over again. All right, I hope everybody has a wonderful day, and thanks so much.
Thank you so much, Dr. Pass, for the last 3 years of every week. I know it's tremendous effort on your part and your teaching mentorship. Thank you so much for everything.
It's a great pleasure.
Thank you so much, Dr. Pass. It's been fun.
It's been fun, and you've learned a lot. You get it right. I got every single one right today. So time to give up the conference. All right. Thanks, guys. Have a good day.